Good evening, everybody. Today we have a very important topic, which is bile duct injuries. It is uncommon, but when it happens, it is a very serious complication, which can impact both the patient, of course, and then the surgeon. Um, Somehow, even though many times the surgeon is extremely careful and follow all the principles of surgery, bile duct injuries does happen, and when it happens, it does impact the surgeon quite hard, because somehow in the deepest crevices of his mind, he thinks that there is something he could have done to avoid or prevent it. uh, I think when we go through the the gamut of the investigations and management of bile duct injuries, we'll get to that. But there are enough evidences till today to show that all the intraoperative devices of intraoperative ultrasound, or the newer screening methods with the indocyanine green and all this, has not shown to prevent bile duct injuries or impact on the management of bile duct injuries. But still, it is a difficult topic, and I think Abdul will go through the presentation, and we will stop in between to discuss, first of all, how to prevent it, and then when it happens, how to manage it. Okay, over to you, Abdul.
Good evening, respected teachers and my dear friends. So my topic is on bile duct injury. So I'll be just talking about the approach to bile duct injury. And so bile duct injury is a dangerous complication of cholecystectomy with the incidence of 0.1 to 0.4 to 1.5% in laparoscopic cholecystectomy compared to open cholecystectomy of 0.2 to 0.3%. It is associated with significant post-operative morbidity and mortality, impairing the long-term quality of life. Injuries are usually complex and require prompt identification and management. Visualization of injuries is hindered by accompanying vascular injury, most commonly the branches of the right hepatic artery. So what are the risk factors for conversion of laparoscopic cholecystectomy to open cholecystectomy? It is gender, male gender, age more than 60 years, obesity, cirrhosis, associated comorbidities, previous upper abdominal surgeries, large bile stones, elevated bilirubin levels, gangrenous cholecystitis, or severe acute or chronic cholecystitis, contracted gallbladder on imaging, and duration of complaints of more than 48 hours. So let's, before we start up with the CVD injuries, let's talk about the anatomy. So cystic duct is 3 to 4 centimeter long with a mean diameter of 4 mm. It runs posterior inferiorly and joins the right border of common hepatic duct to form the common bile duct. Common bile duct is around double the size of cystic duct, approximately 6 to 8 centimeter long. It is divided into supraduodenal, retroduodenal, retropancreatic, and intraduodenal segment. The supraduodenal lies in the right border of the lesser omentum, anterior to the portal vein. So the portal vein can be injured. So the CBD injuries can be associated with injury to portal vein as well as to the hepatic artery proper. The mean external diameter is 9 mm and internal diameter is 8 mm. So the retroduodenal part passes behind the superior part of the duodenum to the right gastroduodenal artery and in front of the portal vein. The posterior superior pancreaticoduodenal artery is a branch of gastroduodenal artery which crosses the CBD anteriorly. And the main supply for the duct system is by this posterior superior pancreaticoduodenal artery in the form of 9 o'clock and 3 o'clock position, which I'll be discussing later. So the arterial supply has a major important implication, especially in liver transplantation, and any damage to the arterial supply can result in development of ischemic changes and strictures. In contrast to the liver, which has a dual blood supply by both the portal vein and the hepatic artery, The duct system, that is both the intrahepatic and extrahepatic duct system, are believed to be totally dependent on the hepatic arterial supply in the form of posterior superior ascending branches from the posterior superior pancreaticoduodenal artery at a 9 o'clock position, and the uh, descending branches of hepatic artery proper. So these form anastomosis around the ducts and then supply the various ductal system. So these are some of the variations of the cystic ducts and the ducts of Luschka, which are important in the ducts of Luschka are abnormal communication, usually between the fundus of the gallbladder to the right hepatic duct or the common hepatic duct. And the variations in cystic duct is it probably gets inserted to the left hepatic duct, or it has a long course in 25% of the patient, has a short cystic duct in 20% of the patient, has a spiral cystic duct which encircles the common hepatic duct in 8 to 20% of the patient. So before we go ahead with the surgery, we should know about the aspects of the critical view of safety, which involves 3 points. One is the visualization of the hepatocystic triangle with no exposure of the common bile duct. The second is the exposure of the lower part of the gallbladder and its separation from the liver bed, and visualization of only two structures that enter the gallbladder, that is the cystic duct and the cystic artery. All these three can be obtained in only 50% of the cases, and the component which is mostly incomplete is the clearance of the lower third of the gallbladder from the liver bed. So if we are not able to attain a critical view of safety, the two bailout procedures which we have is a fundus first approach, where we approach the gallbladder from the fundus, and it is associated with reduced conversion rate to open surgeries and iatrogenic complication, including CVD injury during difficult operation. Subtotal cholecystectomy is associated with surgical site infection and a need for re-intervention and longer hospital stay compared to total cholecystectomy. So what are the imaging that we can do when we intraoperatively? So there are usually three imaging. One is intraoperative cholangiogram, the other one is intraoperative ultrasound, and indocyanine green cholangiography. So intraoperative cholangiography is done to recognize choledocholithiasis and to define the biliary anatomy. This is done by inserting a catheter through the cystic duct and injecting the dye. And this is usually done when there is a suspicion of intraoperative suspicion of bile duct injury and when there is a altered biliary anatomy. Intraoperative ultrasound is usually done to evaluate vascular injuries and this is preferred over hilar dissection during intraoperative staging to avoid further damage of the CVD or the CHD injuries. This is indocyanine green cholangiography. The advantage is non-invasive, quick, safe, easy to do. It is given by intravenous infusion, helps to visualize the structures of the biliary tree, particularly cystic duct, without the need for X-ray imaging. Can be used in acute or chronic gallbladder diseases and in situations where the cholangiography cannot be used. This indocyanine green is once injected, it is metabolized by the liver and secreted into the bile, and hence this is visualized using gamma rays. So CBD injuries can.
Yeah, let's stop this
Yes.
for the time being. Any questions so far?
How many minutes or hours before surgery the indocyanine is injected?
Sir, 5 to 10 minutes before the procedure, before the start of the procedures.
Okay.
Lakshman sir?
Nothing to add. Nothing to add. Thank you.
Can any of the students answer this question? First of all, what is the percentage of injury of major vascular injury associated with bile duct injury? Because that is one of the main important causes, important reasons why bile duct injuries happen. Anybody, Abdul?
So 5 to 10%?
That's a bit high. It is quoted as 4%, maybe 5%. So I think that is one thing. And Pavan, are you there?
Yes, sir.
Okay, what are the steps that you take? I think Abdul has counted as a few of them. What are the steps you take to ensure that you are not injuring the bile duct during laparoscopic or open cholecystectomy?
Yes, sir. First, critical view of safety, sir.
Apart from what he has described.
And have to see any anatomical variations, kind of anatomical variations.
Correct.
And most common thing is that caterpillar humps are to avoid
Moynihan's hump. Yeah, Moynihan's
Moynihan's.
hump.
Yes, sir.
Yes. Yeah. Okay. So that, what else? Indraja?
Yes,
Anything
sir.
to add? Anything to add to what Pavan has already said?
So we should dissect above the Ruvian sulcus. So we should not come beyond the sulcus to.
Okay.
Yes, sir.
What about identification of the cystic node of Lund? Do you dissect below it or above it?
Below.
Anybody else wants to differ with Indraja? Abdul, what other precautions you take when you are doing a cholecystectomy?
So first, a critical view of safety. So
that
stay
you already
away
said.
the Rovius sulcus. Be as close if you are not able to clearly delineate the cystic duct. Be as close to the gallbladder as possible.
Possible. Okay. See, the important things is whenever you see the duct, size of the duct to be a bit large, and you are requesting your nurse to give you a larger clip, think many times before you apply the clip, because a large duct may be not the cystic duct that you are trying to clip. So that is one important thing. Use the electrical energy as little as possible. Of course, this does not apply to everybody, especially in your early stages when you are doing the gallbladder. I think once you are a very experienced surgeon, you know how much to use and what. But whenever in the beginning, always use the energy as little as possible, especially when you are doing the posterior dissection. Even after you have identified the cystic duct, you are now trying to identify the artery, and if you are using the hook, you should be extremely careful, because the hook is an exceptionally good instrument to dissect, but it does not have hemostatic properties. So you may have a lot of bleeding, and in your sort of hurry to control the bleeding, you may clip some structure which may end up to be something different than you would have actually wanted to clip. So hemostasis, you have to be extremely careful. Usage of cautery and electrodiathermy devices, you have to be extremely careful. Sometimes, even though you may not cause immediate bile duct injury, it may cause later strictures of the bile duct, which again is a problem. So you have to be extremely careful. So these are the, and as Pavan said, Moynihan's hump. Again, an artery which is very big, you have to be careful, because the artery goes all the way up and then descends down. So you have to be careful when you do the dissection, so that you don't clip or injure the artery. See, many of this injury to the blood vessels ultimately end up causing injury to the bile duct, because in your hurry to try and control the bleeding, you may sometimes clip some things which may later turn out to be bile duct or right hepatic or whatever. So extremely careful when you are handling the blood vessels. Lakshman sir, anything to add in terms of precautions?
No, I think that covers everything. Yeah, thank you. Yeah.
Srikanth? So the reason why I stressed on these things is, of course, we are talking about bile duct injuries, but the first statement in this has to be prevention of bile duct injury. So you have to do everything in your rights to try and prevent bile duct injuries. Despite this, if it happens, then you will go for, how to manage it. Sir, Lakshman sir, as I was going through the literature, they said that usage of any of these intraoperative devices, still does not, prevent bile duct injuries. What is your opinion, sir?
It reduces the incidence of bile duct injuries, but cannot bring it down to
Prevent.
0%.
Yeah. But they say if there is one study which shows usage, regular or routine usage of one of these methods to people who don't use it,
Yeah.
the bile duct injury rates are similar.
Yeah, that those exceptions are there, but by and large, particularly if you're not sure of the anatomy, it is better to have resort to these special
Indocyanine
thing,
green,
intraoperative
especially
cholangiogram,
indocyanine green.
indocyanine
Yeah.
green or whatever. Or we have mentioned the bailout techniques, doing a subtotal
Yeah.
cholecystectomy.
And fundus first method.
Fundus first method.
And I think I forgot to mention the most important thing. Whenever you have any doubt about the anatomy, call another senior surgeon to come and see if he can make out anything different. Ask him to scrub in, and then him or her, and then both of you,
Very true.
2 brains and 4 eyes are much better.
Very true.
So please do not hesitate to request for help or
Mhm.
advice. Yeah. Okay. Carry on, Abdul.
So this is just a brief overview of all the classification systems of the cystic duct or CBD injury which we have. And initially it was started by Bismuth, which gave only the anatomical reasons for the injury, anatomical classification, followed by Strasbourg. And now presently there is one more classification which have come up known as atom classification, which is anatomic characteristics, timing of detection, and mechanism of injury. So based on that, they have classified. And this also includes the vascular injury, as you can see, the right hepatic artery and the right hepatic duct. So here we are going to stress the most important classification, that is a Strasbourg classification. So bile duct injury can also be divided into mild bile duct injury and minor bile duct injury and major bile duct injury. Minor bile duct injury is Strasbourg classification A to D. Anything beyond E is major bile duct injury, and in that case, in case of major bile duct injury, the ideal treatment is hepaticojejunostomy. Whereas in case of minor bile duct injury, that is A to D, you can use alternative methods like ERCP, stenting to reduce the symptoms. So cystic duct, Strasbourg classification A states that a cystic duct leak or leak from small ducts in the liver bed. Because Strasbourg classification B is occlusion of an aberrant right hepatic duct, and the leak from an aberrant right hepatic duct is Strasbourg classification C, and injury less than 50% of the circumference of the common bile duct is Strasbourg classification D. And beyond that, it is a CHD injury up till the hilar. So the bile duct injury can manage.
Abdul, just a minute.
Yes.
See, there are so many classifications. The common ones, as Abdul said, Strasbourg, Bismuth, and something called Stewart-Wake classification. But now the European Association of Hepatobiliary Surgeons have come up with this atom classification, which includes all the classifications. The advantage of this supposedly is that because it includes all of them, and because it talks about the mechanism of injury as well, in terms of future comparisons of management of bile duct injuries, and for example, comparative studies between different methods and all that, it may help. But I think I don't know whether there is any major advantage of that, because Strasbourg classification has stood the test of time, but the European Association has come up with this new atom classification. Carry on.
So the bile duct injury can...
Before management,
Yes, sir.
Yeah.
under what circumstances there are risk of injury is high?
Yeah, that he has already mentioned, Srikanth. But again, if Abdul, can you repeat them?
So the frozen calyx, the alteration of the normal anatomy, sir, or
Yeah. See, I think main thing is acute cholecystitis after 96 hours, if you are compelled to doing it. Then, as you said, frozen calots, chronic cholecystitis where the gallbladder is very, fibrous and hard, and, empyema of the gallbladder, or if there is Meridzi syndrome, and if there is, significant vascular injury, which then clouds the anatomy, and then while in trying to, control the bleeding, you may injure the bile duct. So these are the sort of circumstances where bile duct injury happens. Shrikant, anything to add?
No, nothing. That's all.
Okay, carry on.
So the bile duct injury will classify the management of the bile duct injury into two aspects. One is when you identify the bile duct injury intraoperatively, and the other one is when you identify the bile duct injury postoperatively. So when you identify a bile duct injury intraoperatively, and you have and if you have a good experience in laparoscopic cholecystectomy without any associated vascular injury, and if it comes under minor bile duct injury classification, that is A, B, C, D, then you can either do a direct repair or with suturing it, or by inserting a T tube into it. And if it is a major bile duct injury and you identify intraoperatively, you can directly repair it with a Roux-en-Y hepaticojejunostomy if it is beyond E, according to Strasbourg classification. And bladder duct injury, if done within 72 hours, that is early, has better success rate compared to after 72 hours. And if there is an associated vascular injury, so it depends on what type of vascular injury you have. If you have a right hepatic artery, it doesn't affect much blood. It doesn't provide much blood supply to the liver, because majority of blood supply is to the portal vein. So in that case, you don't have to repair in some instances. You can just wait and watch. But if there is major vessel injuries like portal vein along with the right hepatic injury, then you have to consider repair or hepatectomy.
Abdul, I think, yeah, I think the literature is, very difficult to this one, because there was a latest paper which I have sent to you, which the problem is the classification of early, hepatic bile duct injuries, and, late and intermediate and all these things. The classification of these are very arbitrary. Some people say within 2 weeks, and some people say up to 6 weeks. And so the late is usually beyond 12 weeks. So there is a lot of arbitrariness about this. So hence it is very difficult to say what is the appropriate timing of the, bile duct injury, repair. But the one thing is for sure, what they say is, unless you are yourself a very good hepatobiliary surgeon and who have done a lot of these repairs, the repair with Roux-en-Y hepaticojejunostomy at the time of surgery tends to lead to much more post-operative strictures and complications. Dr. Lakshman, sir?
Yeah, I agree. It depends on many factors. If you have detected the bile duct damage at the time of surgery, it depends on the degree of damage. You'll then have to get some imaging to make sure what the degree of damage is. And if it is a near transection of the bile duct, which sometimes you can have, you would then be forced to do a hepaticojejunostomy if you have the expertise. And presuming that you have the expertise, you can do it. And I would always recommend, because these are not dilated systems,
Yes.
these are not, there is no docolithiasis. These are maybe 3-4 millimeter anastomosis. So when that happens, always have an access loop and a stent, so that you have access to it if a stricture does occur later.
Yeah. So I think that Dr. Lakshman hit the nail on the head. It is not just your technique. It is because the bile duct is not dilated enough. So the problem is, many of them recommend that you, drain and then wait for a period of whatever, and then do the surgery, which does seem to have a better result. But if you look at across the board, of repairs, the success rate and the complication rates do not reach statistical significance. So though there is slight variations, slight differences, so it depends on lot of circumstances how you actually manage them. Right, carry on.
Sir, in this major injury, sir,
Yes.
can you just put a stent and repair it over it end to end?
See, that is the thing.
Better
See,
or endo side?
See, that is the thing. They say that the complication rates of end-to-end repair over a stent is much more than doing a hepaticojejunostomy, because for the reasons that you just quoted, the blood supply, when there is a transection of the bile duct, the blood supply is lost. So even if you do a proper end-to-end anastomosis over a stent, the chances of stricture because of ischemia is high. So which is why a mucosa to mucosa approximation with a hepaticojejunostomy tends to give you better results.
So there is some guidelines regarding the antibiotic therapy which has to be used. And if intraoperative you find there's a bile duct injury, but it is a minor bile duct injury, after suturing, you can just give the recommended antibiotic would be cefazolin and cefuroxime for 1 day, that is 24 hours. But if you see post-operative, there is infection and ongoing biliary drainage, then you have to step up the antibiotics for minimum of 5 days to piperacillin and tazobactam or a 4th generation cephalosporin. But if a patient goes into shock or sepsis, then high-grade antibiotics using meropenem and piperacillin should be started within 1 hour after the diagnosis, and the treatment should be continued for 5 to 7 days. So post-operatively, how will you identify whether bile duct injury has happened? So patient will present with alarming symptoms of fever, persistent abdominal pain, abdominal distension, jaundice, nausea, and vomiting. And in those patients, and in patients especially who are critically ill, C-reactive protein and procalcitonin and lactate should be done, and serial monitoring is recommended to rule out, to monitor the response of the treatment. And the first diagnostic imaging is the ultrasound abdomen and pelvis. And if you are suspecting any bile duct injury, you have to get a triphasic CT, abdominal CT, to detect any intra-abdominal fluid collection and ductal dilatation. Usually MRCP doesn't have a contrast, but according to guidelines, they say contrast enhanced MRCP provides better visualization, localization, and classification of bile duct injury and is essential for planning the further treatment.
Yes.
So post-operatively, if you detect a bile duct injury, so as you know, as you find out you got the symptoms and the post-operative ultrasound, CT, and the MRCP if you have done, and you identified the bile duct injury. And if it is a minor bile duct injury, and if there is already a drain in place, already after your laparoscopic, when already a drain is placed, you just have to monitor the output of the drain and the vitals of the patient, and usually prefer non-operative management. And if the symptoms worsen, then you have to plan an ERCP and stenting. If there is no drain post-op, so you have to first you have to put a percutaneous drain placement or lavage, and then if symptoms worsen, you have to go ahead with ERCP. Or the patient has jaundice, same, you can go ahead with ERCP directly. If it is a major bile duct injury, that is Strasbourg classification more than E, that is E1 to E5, and if you have diagnosed within 72 hours and the patient is and the patient is fit for surgery, you can go directly and do a Roux-en-Y hepaticojejunostomy. As after 3 days, what happens is there is proliferation and fibrosis of the portal system, and in that case, you have to first drain the system and then only go ahead with the Roux-en-Y hepaticojejunostomy. And once it is after 3 weeks, if you have diagnosed it, you have to give a good lavage and then followed by a Roux-en-Y hepaticojejunostomy. So the indication for the bile leaks can be classified as low grade when during ERCP, the complete ossification is identified when the leak can only be identified after complete ossification of the intrahepatic biliary system. High-grade bile leaks can be observed before the opacification of intrahepatic ducts. So ERCP usually done in mild bile duct injuries and helps in identifying a continued bile leak, provide the anatomical diagnosis, and simultaneously allow treatment of the injury by decompressing or dilating the bile duct. It has more success when the injury to the duct is less than 5 mm and the injury is extrahepatic and not associated with an abscess or a bilioma. But it also comes with associated complications like pancreatitis, bleeding, and cholangitis. The drawback of ERCP is you cannot visualize the ductal system beyond the stricture, that is one, and lack of detection of extrabiliary, that is intrabiliary abnormalities cannot be detected. So usually along with ERCP, we place a plastic tent or a fully covered metallic stent. For biliary strictures, usually plastic tent is preferred. But in those strictures which are located more than 2 centimeters from the main hepatic confluence, self-expanding metallic stent is a better alternative to plastic stent. If ERCP fails, then we go ahead with the percutaneous transhepatic biliary drainage, especially in septic patients who have with a complete obstruction of CBD, and when the surgical repair fails, that is the stricture of the hepaticojejunostomy. The only drawback for percutaneous transhepatic biliary drainage is the presence of a non-dilated system. There it becomes more difficulty and there are more risk of cholangitis in those patients. So Roux-en-Y biliary anastomosis is a gold standard treatment for major bile duct injury in the immediate post-op period, and the incidence of strictures are 4.1 to 69% with a mean incidence of 10 to 20%, and the stricture formation of months of 11 to 30 months. Mortality rate is 1.8 to 4.6%. So how will you manage this anastomotic stricture? Again, percutaneous transhepatic biliary drainage with balloon dilatation is the first line of treatment for management of anastomotic strictures of post-surgery. And at least 1 to 4 times of dilatation is required for approximately 3 months for the success rate to happen. It has a success rate of 66 to 76% with morbidity of 11 to 30%. If this fails, then you have to go ahead with the surgical revision, but it is associated with higher operative morbidity of 30 to 40%. So this step-up procedure approach is required in case of anastomotic strictures. These are my references.
Okay. Right. Pavan,
Yes, sir.
what is your
Oh.
take home message from the class?
WhatsApp ಕಳಿಸಿದ್ದೀನಿ ಎಲ್ಲರಿಗೂ ನಾನು.
Sir.
What is your take home message from the from what you
Yes, sir.
heard just now?
Sir, while performing laparoscopic cholecystectomy, we have to follow the basic step like critical view of steps, safety, and all. And if further, if any bile duct injury is there, so intraoperatively, if we detect, we will put one drain. Or postoperatively, if it is bile leak, whether we can do any ERCP. If it is not possible with ERCP, then if the injury is more obvious, we may require an Roux-en-Y hepatojejunostomy.
Okay. So that's good. You have sort of summarized it well. Let us now go for Sir Lakshman sir.
Yeah, if I may have some-
Hepaticojejunostomy. Can you just highlight the salient features and also the salient steps in the procedure?
Yeah.
Alien steps the presenter should tell, and then Lakshman or you should correct it.
Before that, if I may, let me give some practical tips that are important. At the time of surgery, we have stressed correctly on the various steps. But if you have a leakage of bile that you detect, if it is thin, clear, and light yellowish green, then your antenna must go up to say that it is from the bile duct. Sometimes you can have leakage of bile from the gallbladder side, but you will find that these are darker green. They are also thicker than the light, honey-like bile that comes out of the hepatic duct. Now, when that happens, then you will obviously try to find out where the damage is, which may include, where in centers like ours, where we do not have indocyanine green, an intraoperative cholangiogram. Now, if you do not have a cholangiogram and you cannot detect where the problem is, and you do not obviously have the expertise to open up and look at everything, then the best bailout procedure is to put a nice big drain and make sure that you drain that leak externally rather than allow it to form a bilioma. Cover it with an antibiotic and then either send it to a higher center, or if your own center is able to do it, do an ERCP the next day so that you can delineate where the leak is. And you find that it is a minor leak, you can consider 2 or 3 options. One, a direct suture. If it's a very minor leak and a small part of the CBD is involved, you can suture it over a guide wire, or if it is so small, just an ERCP stent itself might solve the problem for you. You may not even have to open up again. If it is a major CBD injury, then as has been specified, within 3 days, you can consider doing a hepaticojejunostomy, but you must have the experience and the expertise to do that. Now, the problematic thing comes when you get a case or you detect the leak a week or 10 days later. The patient is ill, as Abdul described, unwell, ileus, distension, pain, fever. Then you find a large collection. In those situations, the first thing to do is to drain that collection as much as possible. If it is a generalized biliary peritonitis, you can consider re-laparoscopy and washout, and then drain the subhepatic space so that the subsequent leakage of bile will be drained out rather than giving a general peritonitis. In that situation also, you may consider doing an ARCP to see if a stent can solve the problem. Most of the time it won't, in which case you will have to wait for at least 3 to 4 weeks before you entertain doing any laparotomy and a specific drainage procedure. In the meantime, it is your responsibility to ensure that there is proper external biliary drainage with no generalized sepsis. These simple approaches, if you have clarity, you will address a clinical problem. And yes, Ravi quite correctly pointed out that there are controversies about when you go and what you do. But let me clarify at a practical level. What I have said is more than enough to cover most of the situations. And you would always prefer to do a hepaticojejunostomy rather than any other procedure like a direct repair over a T-tube or a Colli docoduodenostomy and things like that, because hepaticojejunostomy is a time-honored, successful, relatively. I mean, it has its complications, but it's a time-honored, successful method. It's always known that the more proximal your anastomosis, that is, the nearer you are to the hepatic bifurcation, better it is as far as strictures and healing rates are concerned. So if you do it more distally, strictures are more common. Again, it has to do with the blood supply of the bile duct. Your problem will be if the confluence itself is damaged. All right, so it's so high that the confluence itself is damaged, in which case you may have to just put a loop of jejunum onto the hilum. All right, there's nothing, you can actually suture the loop of jejunum onto the hepatic capsule. You cannot get the time-honored and the specified mucosa to mucosa join. It may not be possible, but you have no choice but to do this and accept the inevitable higher stricture rate. If and when that happens, you will then have percutaneous transhepatic radiological procedures to try and bail you out of the situation. That is to you the overall summary of CBD injuries. Thank you. Hepaticojejunostomy, as Shrikant suggested. Abdul, if you want to describe the steps, please. Yeah.
Sir,
Abdul? Yeah.
We do a retrocolic Roux-en-Y hepatococcygeostomy, where we end to side mucosa to mucosa anastomosis of CHD, common hepatic duct, to the jejunum, and approximately around to the proximal jejunum, sir. And
You have to specify how far beyond the
DJ junction.
DJ
plexus.
junction you divide the gut, and what should be the minimum length between the hepaticojejunostomy and the jejunojejunectomy?
sir, I think 30 centimeter from the ligament of tree, so 30 to 35 centimeter around that from the
Too-
ligament
too-
of
Too long. From the ligament of trides, about 3 to 4 inches, which is 10 centimeters. All right, is all that you need. You don't need anything very long, because you don't want a very long segment where bile doesn't reach.
yes,
Okay, you want the bile to reach the food that comes from the duodenal limb as convenient as possible. I think 10 centimeters would be enough. And what should be the length of from the common hepatic duct to this jejunojejunectomy? Should it be short or long?
short, sir.
Short?
I'm not sure.
How can it be short? Why do you not want it to be short?
So we want jejunectomy to act, sir, like to prevent the reflux.
Yeah, you want it to be pretty long,
Yes, sir.
so that food that comes to that area doesn't get back into the biliary tree, right?
Yes, sir.
Yeah, and that should be long. And how long should it be is the question. You would have seen hepaticojejunostomies.
Yes, sir. But
Yeah.
exact
Approximately, I don't, it should be a minimum of 30 to 40 centimeters.
okay, sir.
All right, so that food doesn't reflux. And what is the kind of hepaticojejunostomy that you do? Do you do end to end or end to side?
End to side, sir.
Yeah, end of the common hepatic duct to the side.
Side, yes, sir.
So at your level, you must also know what should be the length of that cut, what are the sutures that you use, and how many sutures that usually that anastomosis takes.
Sir, 40 any monofilament suture, sir.
Like what? What would you use?
PDS.
PDS. All right. PDS is acceptable. Yeah.
And
Yeah. One practical tip, you may not have noticed it. When you make the cut on the jejunum, it invariably expands. So if you have, say, a 5 or 6 mm common hepatic duct, if you make a 5 mm cut on your jejunum, it will become 10 mm by the time you keep putting these stitches. So always make it shorter. All right. So you will see many hepatic HPB surgeons making just a little puncture hole into that jejunum. And by the time they keep placing these sutures, it will have expanded. So the message is, make the cut on the jejunal side smaller than your diameter of the common hepatic duct. Posterior layer is always a little difficult. Place the posterior layer first and then parachute it. Place the sutures but don't tie them. Push the jejunal loop down on these posterior layer first, and then the anterior layer can be dealt with. So PDS is a reasonable stitch. Always drain the area with either a suction drain or an ADK. And as I mentioned earlier, if you have a 4 mm or 3 mm common hepatic duct, which you can have at times, it's a very small duct, always have an access loop and a stent. You'll have to tell me what an access loop is now.
Abdul?
so I have no idea, sir.
Okay. Access loop, okay. Anybody else? Indraja, anybody else?
Indraja and Pooja were present during the surgery,
Yeah.
and we
So
were
Shruti,
discussing
good
the-
evening. Shruti, good
Shruti,
evening.
yeah.
Thank you.
All right. You want to add
Sorry.
anything? You want to add anything, Shruti? Go ahead. You might. I don't know how when you got in and how
I
much.
joined late, sir.
All
Sorry,
right.
I was traveling for the
No problem,
weekend
no
and
problem.
I got late from work.
Yeah. If you heard what I said, if you have anything to add, please.
Yeah, I joined when you were discussing the length of the Roux loop, and I think
Okay, that's good. Yeah.
you would have discussed quite a lot. I have
Before that,
no,
yes.
the access loop. Basically, Indraja or Pooja should answer this.
Puja is from
Otherwise-
now there.
Puja is on
Puja is
vacation
on,
today. Yeah.
on vacation.
Okay,
Indraja.
Indraja?
In infant feeding tube or
No, no,
Oh, no. Okay.
What did we talk about, Isan, when we?
If you have actually watched Shruti do an operation, you must know what it is, Indraja. All right, Shruti, please enlighten
Okay,
us.
we'll just make it short. Yeah.
Yeah,
No,
yeah.
access loop, as we were discussing, like in difficult injuries and cases where you're thinking that it might need some interventions, there's a possibility of restructuring, etc. To have, because you've done a rule loop, there is no scope for ERCP. At least it's very difficult to do a ERCP in rule loop anatomy, which is why you do a access loop. Basically, the stapled end of the rule loop, what you've brought up, and you've done that end to side hip edge, that staple end, you leave it slightly long and you kind of bring it out as a stoma. And this can be either left as an open stoma and you put a bag around that, or you bring that loop and leave it in the subcutaneous plane, so that it can be accessed via, you can, the interventional radiologist can puncture and dilate, and then they can do a scopy through that. Or another internal access loop is where they make that, with that stapled end, they open that stapled end and they join it to the lesser curvature of the stomach or the anterior surface of the stomach, so that gastroscope, when they do gastroscopy, and they'll be able to access this directly. And again, this is more for academic purpose. It is important to know that by far the practice of access loops has come down these days, because our interventional radiology facilities have increased. And in case there is a hip edge stricture which you're not planning to redo because it's very high or something, it's usually the interventional radiologists who will come to our rescue and they'll do PTBD, and then they'll be able to push that PTBD across the previous hip edge, and they'll place stents. And these days there's covered metallic stents which are available. They'll place that, and that will be able to maintain the patency of these things over a long time. I don't know. I think all of these would have been discussed. Just one small thing which I would, for the sake of PGs, if I have to say something, biliary strictures, biliary injuries, again, prevention is one aspect and management is one aspect. Prevention is a totally different thing, safe cholecystectomy, and it's a different pathway to discuss on. Management, again, at least when you're thinking of it at the general surgery level, people tend to think of established strictures, how to manage them, etc. One thing also, as general surgeons who will be entering into practice in the near future, that you guys will have to be aware of is about early repairs. Now, early repairs, again, this is just a decade ago when I was in training. It was everyone used to fear early repairs, and it was a strict no, especially in the presence of inflammation and acute cholecystitis and mirices, because these are the risk factors for a biliary injury. And in that, they'll say that you should try and not do a early repair in those kind of things. But then off late, with the I should say, as a liver transplant surgeon, I'm biased here a bit, so forgive me, sir. But then with better understanding of this, and because we are seeing more of these things being done when we are doing liver transplants, we always do bile duct to bile duct anastomosis. And as long as the ends of the bile duct are healthy and bleeding, and there is no cautery injury, there's no long segment leak, there's no long segment loss of bile duct, it's okay to do a early repair. So, but then one has to be very clear that if you cause injury, at a point of time, you should try and do the repair by yourself. There is always that in cholecystectomy, even if the most experienced person has done cholecystectomy, if there is a biliary injury, it's because of that perception bias, what they say, that, somehow the way we are looking at the anatomy, we are looking at it in a certain way, and then it's hard for us to, repicturize it in a different way. So it's also always important to call a friend to be able to call a equally capable or someone more senior into the picture if there is acute injury. And again, I'm not saying all these acute injuries can be repaired, early repairs can be done, but then you can do early repairs up to 24, 48, and even up to 72 hours. Probably for your question and answer sake, keep it to 24 to 48 hours, no, not more than that. But then in practice, 24, 48, 72 hours, as long as the anatomy and the bile ducts are all okay. And especially if it is something which you've detected intraoperatively and which you can call someone intraoperatively, if the facility is, you're working in a setup where you have the facilities to be able to manage such a thing, fine sutures, fine instruments, all of that, it's something which can be done.
Yeah.
Shruti,
that's
I'm
the only
glad to
thing.
say that as general surgeons, I and Ravi said exactly the same thing that you have summarized during the whole
Yeah.
section.
So I will just,
It's very nice
You
that
both
you.
are not general surgeons, sir.
Yeah.
Both of you are
No.
expert GI surgeons who've been in practice for a long time. So you
Yeah,
are
yeah,
speaking
but-
out of your experience.
I'll just quote you figures, everybody. So if you look at large series of about 50 or 1,000 cholecystectomies in which there was bile duct injury, 14% of them repair was done immediately, 28% of them was done at early repair, 28% delayed repair, and 26% late repair. But the good thing is that complication rate, morbidity, mortality, and stricture rates are all similar, though there may be minor differences. Then none of them reach statistical significance. So I think it is, as Sir said very clearly before, and as Shruti has also very clearly delineated, there are so many circumstances which actually dictate when you do the repair. So if the patient is not well, patient is septic, and things like that, it is one of the most important thing is do not try to do the repair then. Put a drain, come out, let the patient get better, then you can handle the problem. So there are a lot of these things are there. And of course, the surgeon's technique and surgeon's quality of repair is very important. One of the things that determine post-operative strictures. So all of these things are, to be borne in mind when you do the repair, when to do. There is no hard and fast rule. I think it is very difficult to conduct a randomized controlled trial about bile duct injuries because you don't know when it happens. So a prospective trial is out of question. Most of the information that we have are well conducted retrospective studies, which means they have followed a lot of these, the principles of, the data collection and making sure that the data collected is true and, no corruption of the data has happened and things like that.
And
So
just one more.
Yeah, Shruti, go on.
Nothing. I mean, I was just, this was one of my questions in my MS general surgery final exams. And just for the PGs, if you get some of these kind of questions, it's so easy to write the whole of the answer as a flow chart, as an algorithm kind of answer rather than writing paragraphs. So make a habit. I mean, after you've heard this lecture, you will read about it and just try to make a flowchart for yourself, write it in a book or on a page and stick it somewhere. And what do you do early or medium term or late, and what are the types and what kind of repair you do. It's all like, not a single line should be in a paragraph form. You can write it like that. Just make that happen.
Yeah. Shruti,
Primary repair, whether it is done on over a stent or without stent.
Sir, not always stents are needed. These days, we even 3 to 4 ducts also we do. And, when we are doing pediatric transplants and everything, we are invariably, because the stents that we are talking about, the smallest infant feeding tube that you are talking about is 6 French. Sometimes the size of the bile duct itself will be, that size or sometimes even smaller than that. So now there are bioabsorbable stents, which have come into the market. It's recently come into the Indian market. It's called Archimedes stent. It's basically PDS kind of material. It will dissolve. But then again, these stents don't come in small sizes. I think the standard sizes that they are coming, the smallest size is 5 French or something, and 7 French and 10 French. These are the three sizes which are available. So, but then if you are able to put this size stent into a duct, then it means that anastomosis is not, I mean, that's a safe thing. I wouldn't be afraid about 4 mm, 5 mm duct. Anything smaller, especially the pediatric ducts, when we are doing living donors with multiple ducts, those are the ones which are prone for leak. And in those kind of things, we don't have small size stents available. In general, people have moved away from stents for the same reason.
Shruti,
Sir?
the classification of bile duct strictures or bile duct injuries, still
Yes.
is the Strasbourg, that is the standard, or what is the new atom classification? Is that used regularly?
Sorry, which classification?
Atom classification from the European Society of Hepatobiliary Surgeons.
I remember this is atom is A and T, and each of them has one
correct.
numbers.
Yeah, it's an acronym. Yeah. Yes, it is an
acronym. Yeah. So I mean, I remember reading it this thing, but in practice, we are so used to going by the Strasbourg classification. We don't actually use atom classification.
Yeah, I think
good for the PGs to know, but then in practice, no one uses.
Yeah, I think Strasbourg is what you should remember. I think that should be safe.
And even in Strasbourg, just this, I think type 3 and type 4, if I'm right. This is type 3 or type 4, or is it C or D? Sorry, I'm bad with this thing now. So, I mean, this is E3 and E4. I think the difference is separated ducts or, if there is a common cuff. In that, I remember reading one very nice article where they have said that it's not about whether the ducts are fully separate or this thing, whether the bridge is there between the ducts or not. So usually there will be 2 separate orifices, but then the upper part, the part of the duct which is against the hilar plate, if that is available, then you'll be able to make a common orifice.
Yeah.
So despite us using Strasbourg classification, part of it is when you open it, what is the anatomy? Like in our case, when we were doing that, I was hell-bent on finding normal mucosa. That's nowhere written that if there is no normal mucosa, it's a different kind of stricture or something. It's just the base, the fundamentals behind that classification should also be known by the PGs.
Yeah. Okay, I think we had good discussion. I don't think there's much to add. Srikanth, final thoughts?
What can I add? No, I can only minus.
Lakshman sir?
Nothing at all. Nothing. I think
When Shruti has come,
yeah.
Rawalpindi Express.
Students, anybody want to talk about the slides and the...
Why the post DNB student present? It is something. Final year pages should present. It's an exam question.
No, I think
we are reducing the workload for the PGs, and we want to keep the registrars and consultants involved. So you'll see that.
But you said you are out of station 25th to 5th. Everyone were happy.
He came back.
I didn't want them to be happy. So I cancelled my trip and I got back. Yeah. Anyway, we are, we will involve you also, Srikanth. So we are all going to.
Yes, faculty lecture.
Faculty lectures will increase this year. All right. And Shruti, of course, will
Shruti can come and give a faculty lecture.
We will have these things. Yeah. Okay.
Next to bile duct strictures they can present.
Yeah. I think it was good. So
sorry, Shruti, you had something to say, Shruti?
Yeah, Shruti.
No, I was just asking if the PGs had any questions for themselves.
Yeah. PGs. Pawan, what did you think of the presentation? Any questions, final thoughts?
Sir, presentations did good, sir, and slides are also good. And I got a good idea regarding the biliary bile duct injury.
Okay, good.
You're talking like a faculty in one of our conferences where they go and comment rather than question.
Sorry.
No. You should not be sorry, B. I mean, it's a kind of maturity that you had in that, giving the compliments to the speakers before you ask something. But then it's also that if you have any doubts, now is the time to ask. You should ask it now.
Anybody has any questions or doubts?
Hello, sir.
Yeah,
Go
Vinod.
on, Vinod.
Sir, this type E classification is there, sir. Actually, they mention it as a stricture, sir. Is it a stricture or an injury, sir?
It can be applied both for a stricture or an injury also.
But then in intrahepatic, how can we diagnose a stricture, sir?
There is no intrahepatic, no? It is all hilum.
No, sir. Intraoperatively,
Huh.
how can we diagnose a stricture?
So that,
Can you put that slide back?
Which one, ma'am? Hello.
Shruti,
Shruti,
which one?
unmute yourself, Shruti.
Shruti, yeah.
Okay, sir. Yeah. What's your question, Vinod?
Ma'am,
He's
actually,
asking, yeah, Vinod's question is, how do we diagnose strictures in the operative phase, per operatively? Vinod, you're not talking about strictures here at all. Okay. The classification of injury where there is a cut or a damage to the bile duct is what you see in bile duct injuries, which we are discussing today. Okay, a late effect of this or whatever else or intervention in the biliary tree can be a stricture. There also classification depends on the level of the stricture in relation to whether it's at the lower end or the middle or the upper end of the bile duct, or whether it involves the individual hepatic ducts. So you have similar classifications for stricture and similar classifications of damage, where you find only bile leak. And that's what we're talking about today. We will have another class on strictures.
So Strasbourg is classification for biliary injuries. Bismuth is for strictures. And if for the sake of completeness, the Strasbourg includes the bismuth in its type E classification. So, but then if you look at the original papers, Strasbourg is injuries and bismuth is strictures. And one doubt, and there's a basic this thing. It's a spotter for the PGs. If you look at this type D injury, and you tell what is unusual or what's funny about that picture. Don't look at the description and everything. Look at the injury type D in the slide and tell what is funny. Yeah, that one.
Well, injury is on the opposite side and it is above.
It can be above. I mean, yeah.
Go on, Shruti. Tell them. Yeah.
Shruti, I think her
Early paper and original paper, and it kept coming like this. But then it's not on the left side. The injury will usually be on the right side. I think for the sake of pictorial depiction and to prevent confusion between cystic duct, stump leaks, etc., the original paper put it on the left side. But most of the times our injuries are on the right side.
Right side.
Yeah.
You should be very adventurous to make an injury on the left side.
But there is an explanation for that also, Shruti, and that would be cautery injuries. Right?
Yeah.
The cautery, even though it's mechanically, it is on the same side. You can have the jumping current with cautery, and it can happen on the other side. There have been descriptions of the left hepatic duct injuries during cholecystectomy. You think it's far away from where you're operating, but you can have that kind of injury conduction injuries.
Yeah.
Okay. So I think it was a very helpful, very good class. I think Abdul, a lot of clarity in your presentation, a lot of as Shruti said, the classification and flow charts and the algorithmic approach. I think all of you, please, I think Abdul, please share this presentation with everybody so that they keep this as, notes for themselves for the examination, how they approach it. So that was good. I think good discussion and good tips from Dr. Lakshman, Dr. Shruti about how to avoid bile duct injuries and how to manage them when it happens. So I think it was a very, very useful, very good class. And thank you everybody for active participation. Good night.
Good night.
Good night.
Thank you. Thank you.
Thank you.
Good
Thank you,
night.
Shruti. Thank you for coming.
No, I'm happy, sir. Thank you.